everybody. I'm Kandra. Is this your first meeting of the year for this organization? No? Nobody knows? Nobody knows. Okay. Well, I was here last year, asked by Emma, that I guess was chairing the organization last year. So I'm cheating, and I've got the same thing. So if you were here last year, I'm sorry that that you're seeing a repeat. But I am a PA, which is a physician assistant, and I work at St. Francis with the trauma surgery team and the general surgery team. So I've got kind of a fun job and a little bit interesting, and I've got some gory pictures to make everybody happy if you like that sort of thing. So I'm just going to tell you a little bit about what it means to be a PA. So that you guys know as you're kind of thinking about college and life in the future, and if that's something that you're going to be interested in. So first off, here's just a little bit like what we are and what we aren't. PAs are professionals and members of the healthcare team. We've been to college, we have a bachelor's degree, and we have a master's degree. There are some doctorate degrees for PAs, but most of us don't have those that are practicing right now. We are members of the team, so just like you may or may not know, you have from doctors and nurses, those are very common professions, physical therapists, that sort of thing. We're just another member of the team. We often work independently, so a lot of times when you think about, like I just told you what PA stood for is physician assistant. I think that assistant has kind of been a bad title for us, and so we sort of get, a lot of people think we just sort of do what physicians tell us to do, but that's not really how we work. I mean, we do work very closely with physicians, but we make independent decisions all day, every day, sometimes never, speaking to the physician about decisions that we make. So, like I said, we're well trained with at least a master's degree and a lot of clinical hours before we graduate from school. So we're not doctor's assistants. We don't work completely independently. We always have a physician as part of our team that is available to us for more complex cases. And we're not nurse practitioners. You may or may not know nurse practitioners. You may see one. You may have one in your family. Or a neighbor or something like that, and we are a very similar profession, but we're not the same. One basic difference is that nurse practitioners went to college and they were nurses before they were nurse practitioners, and PAs do not have that piece. So oftentimes our majors in college are something that you might think of other pre-healthcare majors. Can be sciences like biology, chemistry, biochemistry, can be a pre-med type major. So that's what you'll see most of us in undergraduate doing. So just a couple little things from that I found from our national organization online. So we've been a profession for a long time, over 50 years, 56 years to be exact. There's 150,000 PAs in the country, and this information is probably like 2021, so it might be a little bit old. And we see 400 million patients a year, so we impact a lot of patients in the healthcare system. To be a PA, you have to attend graduate school. You have to be accepted. Usually the programs are about 24 to 36 months long after college, so you're talking another 2 to 3 years. That includes what's called the didactic time, which is like classroom setting where you're taking science classes, physiology, pathophysiology, microbiology, a lot of just basic science things that are more advanced from an undergraduate degree. And then after 12 months it's clinical time, so you start into clinical rotations. And there are certain rotations you have to be able to graduate and sit for your boards. Everything from family practice, internal medicine, psychiatry, obstetrics and gynecology, pediatrics, surgery. You have to be exposed to all the different things. We have to do a lot of continuing education to maintain our license. So you know, to stay abreast on medical knowledge and current medical knowledge and treatment. So we have to do a lot of those things. We have to sit for a national certification exam, and then you get licensed by the state that you practice in. So if you move from state to state, you have to get relicensed when you move, which is oftentimes not a big deal. You don't have to take another exam. It's just an application process. So we work everywhere in healthcare, from the office, you know, like just like if you were going in to get an annual checkup or you were going in for a sore throat, we work in that kind of setting. We work in urgent cares. We work in hospitals, surgery centers, mental health hospitals. What else am I forgetting at? So this is just saying, you know, this color here is the hospital, this is outpatient, and this over here is the different specialties you can work in. So a lot of us are in surgical specialties, emergency medicine, hospital medicine. We're all over the place. So you may not know that you've seen one of us, but you probably have at some point if you've been to the office at all. Let's see, what year was that? 2021. We were the #1 best job in the country. That's pretty cool. I was pretty proud of that, to say I had the best job in the country. I don't always think it's the best job, but apparently other people think it is. Yeah, so we're a fastly growing profession. A lot of reasons for that you guys may not think about, because, you know, you're young people, but really the world is really old. And we have a lot of really old people in the world now. And medicine is really good. Surgery is really good. And so people are living longer. In addition to just that, you know, we had a baby boomer generation. So there were more people born, but now they're not necessarily dying. Like, I've been in healthcare since about 2001. And so, you know, it was pretty rare to see like 80-year-olds during that time. You know, you thought like somebody really made it a long time in their life if they were in their 80s. And now, I mean, we see 90-year-olds all the time, and 80-year-olds are very common. So just in like the 20 years I've been working in healthcare, I've noticed that. And so because medicine is so good, people are living longer. You know, you can get stents in your heart, and you get a surgery to fix this and a pill to fix that, and people are really living a long time. All right, so I've been a PA for actually almost 13 years now, because I cheated and didn't update my slides. This is me in our, what we call our trauma bay at St. Francis, and this is me in the ICU at like 3 o'clock in the morning during COVID when we had to wear our masks. I was actually, interestingly, I had a career in healthcare before I went to PA school. So like I said, I've been working in healthcare since 2001, but I've only been a PA since 2010. My job is with the trauma team and what we call acute care surgery. So trauma, you guys probably know what that means. That's people who get hurt in car crashes or falls, or fell out of a deer stand, got shot or stabbed, was trimming trees and a log fell on me. I'm really old and I fell right here on the floor, you know, like all kinds of things. And then acute care surgery means general surgery. So I know I'm kind of getting into the weeds for some things, but that's a lot of abdominal surgery, okay, like intestinal, stomach surgery. But when I say acute care, it means the people that come into the hospital to the ER with problems. So like I have appendicitis, my gallbladder's bad, different things with the intestines. That's the work we do. We don't do the surgeries that are scheduled, like I have a colon cancer that I know about that I need removed. That stuff goes through the office. That's what we call elective surgery. We do the stuff that comes in through the hospital. Yeah, go ahead.
Is the gallbladder ever an emergency removal?
Yeah, sometimes. Yeah. It can be sick and inflamed, and you know, there's a lot of important ducts there. If you get a stone lodged in the wrong spot, that can be a bad problem. So yes, it can be. Yeah.
And what did you do? You said you were in healthcare before you were a PA. What did you do before that?
I was actually a nurse before that.
Okay.
Yeah. So I was a nurse for about I guess 7 years before I started school, and then I didn't work during my master's degree. So
you could have selected the PA route or the practitioner route.
Correct.
Can I ask why you picked one
Sure.
that you did?
Yeah. So I know that 2008 doesn't feel that long ago to you and me. I mean, these guys were like, not even probably just some of them were born then. But at that time, when you were a nurse practitioner, you mostly got educated to work in an office type setting.
Gotcha.
And so I knew I wanted to work more in the hospital type setting.
Okay.
And so the PA route was a better fit for that.
Perfect.
So yeah, that's why I went that route. Since that time, there's been some more education for the nurse practitioners as far as for the hospital-based setting. So yeah. I do. Oh yeah, go.
Do you enjoy this more than being a nurse?
They're very different jobs. They're very different. I really liked being a nurse. And sometimes I think that I would enjoy doing it again. And there's still parts of my job that cross over, but it is full of different challenges. And what I enjoy about it is sort of solving the puzzle of what's wrong with the patient. And you can do that as a nurse, but it's sort of like you sort of like went to the next level of thinking. A lot of nurses don't necessarily take that next step to how they're understanding things. So I really enjoy that. Yeah.
Since being like a nurse, obviously you can branch off more than just a practitioner.
Yeah.
Was there anything else you questioned or looked into before you became a physician assistant?
When I went to college to be a nurse, my goal was to be a nurse anesthetist. I don't know if you know what that is.
I do.
Nurse anesthetists are, they have a master's degree also, and they are the ones that are responsible for your anesthesia when you have procedures. So whether or not you're having a tooth pulled or whether you're having, a surgery or something like that. And when I got into into college and then got into my nursing program, I really liked interacting with the patients. And in my mind, I made up that the nurse anesthetists don't really interact with the patients because they're asleep all the time, right? I mean, you have to put them to sleep. So I know better now, but in my mind, I wanted to talk to the patients and interact with the patients and be with the patients. So and I pretty early on knew that that wasn't for me. The thing about healthcare that you guys may not realize is it can be very variable from what hospital or what community or what city you live in. And so, my job looks like what it looks like for me in Cape Girardeau, but what it would look like in St. Louis versus what it looked like in Chicago versus I actually worked in Columbia. We used to live there. I worked at the hospital at Mizzou. It was quite different than what I do now. Similarities, but yet differences. And so a lot of these professions, it's hard to just make a snapshot of it because they can be quite variable. Yeah.
Would you mind elaborating just a little bit, between Cape Girardeau and Columbia?
Sure.
What was the difference between the jobs?
Well, I think so. There was just a difference in people I encountered when I was at Mizzou. We're training residents there, so I'm interacting with a lot of people that are in their when they start their surgery residency. If they went straight from college to med school to then residency, they're 26, which is about how old I was at the time. So I had a bunch of, people that I'm interacting with, but they're also learning. So it's you're constantly being fed information from the attending physicians and surgeons about different things what is acidosis? Why is acidosis bad for the body? Why do patients get acidotic when they're bleeding? And you hear that even though they're not always directly talking to me because their duty is not to educate me, their duty is to educate the residents and the med students, but you just hear all that all the time. And so then being at a big hospital like that, because education is so important, they are always practicing the most up-to-date medicine. It's just, I mean, that's just what they do. You know, they're doing research or they're reading the journals and practicing the most up to date. And you come to a smaller community like ours where you have the physicians have been, they've been through that training and then they get settled into their community and they sort of get into a comfort zone where maybe everything is not cutting edge or the hospital doesn't have all the cutting edge, can't do all the things, you know, and so you kind of feel like you can get a little more stagnant in a smaller hospital like we have as compared to like a bigger hospital that's a teaching hospital. Yeah. And you know, you can imagine too, based on geography, where you live, you can have different obstacles like language barriers, socioeconomic barriers, like do patients and their families have the funds to be able to pay for what they need or to get the follow-up, and so you can see a lot of different things where patients haven't been taking care of their health, and then that's just a huge snowball effect of to how sick they are. So there's a lot that can play into that. Unfortunately, I got to work all the days and nights and holidays and weekends. I mean, not all of them. They let me have some of them off. But I'm in the hospital. You could call me at 2 a.m. and I might be at work. So it just varies the kind of shifts that I have to do. Like this week, I'm working 3 12-hour day shifts. Last week, I worked a 24-hour shift on Sunday and a Monday night and a Wednesday, Thursday day shift. So, you know, it's kind of crazy and all over the place. But I always tell myself that when I'm at work, I always have an interaction with the patient in those off hours that I wish I wasn't there that is meaningful. You know, I mean, sometimes I get lucky and I can lay down on the call bed and the phone doesn't ring from like midnight to 6 and I think I hit the jackpot. But if I have a patient interaction, I always know I provided service, you know, that was beneficial to the patient. So, all right, I don't really know if I have a slide before the gory pictures, so I can't remember. So if it just like jumps into a bloody picture, there you go. Yeah, good bloody picture. Okay, so let me like step back.
Do you want me to shut the front light on?
Maybe. I was just going to try to orient myself so I could tell you. So. This was a patient that we had probably, I'm going to say 6 years ago. The blue drapes are covering the patient's head. Okay, so anesthesia stands on the other side of the blue drapes. And the patient was shot in the chest and the belly. So their head is, oh, I didn't do that. I didn't mean to. Talking with my hands a little too much, sorry. So head is on the right, feet are on the left. And we initially started off with what we call a laparotomy, which is when you make an incision from kind of like the bottom of your breastbone down to like your pubic bone, you know, where you feel down by your bladder. So we make a big like vertical incision like that. We go around the belly button. So this is like some colon here. This is the liver. This is the diaphragm here. And then this gentleman was shot in the chest too, so he had blood draining out of his chest and a drain we had there, and we needed to control that. So then we opened up his chest with a thoracotomy incision. This big silver ring is called a Bookwalter, which is like a self-retaining retractor that we can put in so that we don't have to have a human, you know, holding things back out of the way. This is a suction device. This is what we call lap pads, which you use to soak up the blood. This is the lung here. So, yeah.
So do you have to have, because like you got a general surgeon there
Yeah.
for the abdominal stuff. So like this patient that was shot also in the lungs, do you have to have a thoracic surgeon there?
Yes, I mean, general surgeons are very well trained. A lot of that turns out into like, how often are you doing this? And are you the most skilled person to do this surgery? So I think most of our surgeons are very, getting in there to do kind of the life-saving thing, whether that means a clamp or a stitch or something like that to stop the bleeding, while we're getting the thoracic surgery team in to sort of like give us a definitive management.
Gotcha.
Yeah. And there was a thoracic surgeon involved on this case too, so. And he lived.
Okay, I was gonna
Yeah.
ask you the outcome.
I don't know that I have any pictures of anybody that died. I feel like I'm gonna play the drums here in just a second, but I don't know how. But so this is a procedure that we do in trauma surgery for patients with broken ribs. And you guys probably haven't had any broken ribs because you're kids and your ribs don't break very easily. But you all are getting ready to be into adulthood and they're going to start breaking easy. And so, if you have a bad car crash where you get T-boned, hit from the side and your ribs can get impacted, or you fall just right, like these old people that fall and break their ribs all the time. So this is a CAT scan that has been done in what we call 3D reconstruction. So you can see the ribs here. The ribs connect to your vertebrae in the back and they come around, they connect to your breastbone in the front except the lower ones. Yeah?
So, wait, the image we're seeing on the upper left-hand side
These?
is one, they basically took a CT scan and were able to reconstruct.
Right.
That is amazing.
Yeah, pretty good, right?
Holy cow.
Yeah. So the shoulder blade is missing. We usually have them take the shoulder blade off in that because the ribs are often broken under the shoulder blade and so it's hard to see. But you can see the ribs are broken here. That's the collarbone that's coming up. That's a kidney. We don't need to know that. We just needed the bones, but they left all the organs in there. And so then when you come over here and you can see, that's a chest x-ray after we did it, but you can see here we do a small, why is it doing this?
I don't know, I've never seen it. That's kind of cool.
Okay. She's messing with it over there. Zoom back out.
All right, well, I don't know how we got in or out. But
Yeah,
that's-
so we make a little incision here at the chest and we get down to the ribs and we put these little plates on the ribs to kind of, what happens in a situation like this is ribs will heal on their own. And the nice thing about ribs is it doesn't really matter what they look like. They don't cause your chest to be deformed. It doesn't affect your breathing if they heal like a little bent like this or if they heal overlapped. But what happens in a situation like this is, you've got ribs, you've got 12 on each side, and so you're breathing 15 times a minute. And when those muscles cause you to breathe, those ribs kind of clunk against each other. And the patients tell you it pops, it hurts, it burns, I can't breathe. And so then their body tells their brain to not breathe as deep, and so then they start taking these little baby breaths, and then they get pneumonia and all these other complications. So if we put these plates on the chest, then the ribs don't kind of clunk back and forth with the breathing, then they can breathe better, and they have less pain, they get out of hospital quicker, that sort of thing. Yeah?
So what happened to this person that they broke? How many ribs is that? 7 or 8?
Yeah,
broken?
probably 1, 2, 3, 4, 5, 6, 7, 8. I don't remember what happened to him.
Okay.
I mean, literally before I got here, I'm just admitting an old man to the hospital who's like 90 who has 10 broken ribs
Oh,
and a
wow.
broken scapula and clavicle from a fall on Saturday.
Wow.
Like fall from just standing?
Yeah.
Oh my gosh.
Drink your milk with your Oreos,
Yes, to be
please.
super to be young.
Yeah,
Gosh, to be young.
Yeah, yeah.
Maybe to
While you're young.
yeah.
Okay.
Drink milk while you're young with your Oreos and then go on a walk, and I think you'll be fine. So these are some lacerations that I've taken care of. I don't know that I always have the after photo. I'm pretty sure I don't, but this is this picture always makes me think of like the Three Stooges, who I know you guys don't know who it is, but I always think of like Curly or Mo or what.
Larry, I think.
Yeah, whichever, but like bald down the middle with his curly hair. But we had to shave her hair, and she just fell and hit her head on. I think like something at the tire shop or something, and just split her head wide open. So this is the top of her head, and like that's her nose that way. Scalps they bleed a whole lot. So if you ever are near anybody that has a scalp laceration or a cut on their head or face, it's a very vascular part of your body, so you can bleed a lot from there. This is pretty easily fixed. We use staples a lot on the scalp. Now when it gets down into the face, we don't use staples on the face because that's disfiguring and leaves more of a scar, but we use staples all the time on the scalp, and it just comes, it looks like, well, there is one that's kind of flat like a staple gun, but the one I like looks more like a gun. It has more of a barrel to it, and you pull in. So it works really nice to bring the skin together.
And it doesn't like staple it into the skull or anything.
No, it just staples the skin together.
So like grabs both sides and brings
Yeah,
it
well, we
together?
kind of have to help it, you know. I mean, if it's gapped like this, you have to pull it together. But yeah,
Does
it
this-
goes and then they curl just like they do on paper. They just curl in like this into the skin.
So is there a part of the stapler that goes like underneath the
No.
skin? Wow.
No,
Okay.
yeah, it just grabs the skin and kind of pulls it up and staples it. So
Okay.
you have to leave them in about 7 to 10 days on the scalp. This was a good ear laceration with, you can see some cartilage exposed there. We see those kind of things a lot from ATV crashes, because nobody ever wears the helmet on the ATV, which you should do. But yes, we see a lot of things like that. Oh, yeah, this was a good story. So this guy was impaled in a car crash on a fence post. You know, like your chain link fence in your backyard. So that was interesting. I'm trying to get my orientation. So his head is right here. The post is coming in like right here, and then bends and comes out kind of underneath his right arm.
So
So
they
like,
have to like dig it out for him to go to the hospital?
well, I think they just cut it off,
That's
probably the
probably a
fence
better
post, yeah. And he went to surgery and was a young guy, like in his 20s, and actually didn't have very major injuries considering. Some broken ribs, and I think they did take out a little bit of his lung, but I mean, really not much major. And went home, you know, lived to tell about it and went home. So you can see some pretty wild things. I wasn't here when he came in. That would have been pretty wicked to see. There isn't much that I need to see anymore in my life, but that would have been pretty wicked to see. These are this is interesting to me because you guys would never think this would happen. It started out like this. That's the knee. So you just got a little cut right here over the flat part just below your knee where there's like not really any fat or muscle over it. And so we repaired it and it looked like this, and see how it's all blue and kind of dusky? That's not a very good sign because it's lack of blood supply and things like that. And then the whole the skin all died. And then we had to take all the skin off the leg. So that's fascia and muscle there.
Wait, so did you have to like, how did you fix that?
Well, then you let that heal a little bit on its own so that you can attach a skin graft to it. Yeah. But his leg it will work fine, but it will look disfigured as far as, I don't know if you guys have ever seen anybody that's had a skin graft or that they've had people that you'll see them and you're like on their leg or their arm, like, why does it seem like there's a chunk out? Like, you know, that all that like subcutaneous tissue and muscle and stuff doesn't all come back. So, and the skin after a skin graft is it's irregular. It's not smooth. Like,
Is it actual skin though that they use?
yeah, so when you do a skin graft, you usually take skin from the thigh is often a place. And so a device like a planer, like if you were working on wood and like taking off some of the wood, that's what you use to take the skin off. And usually, you know, you'll take off a piece like this, and then it's put through a device that meshes it like a screen on a screen door so that it gets bigger. So instead of it being this big, it's, you know, this big because you created holes in it. And then you attach that to the place that needs the skin, and the body fills those meshed spots in. So the body will get a blood supply from the site there to the skin, and will fill all that in.
So that, I'm sorry,
I think you have the most.
I do, I'm fascinated. If you guys have questions, I'm sorry, I take up the, okay, but when they use the planer, is that off of the same person?
Yes,
So that will take, like, I need a piece of skin that covers all this.
right,
They're gonna take a piece of skin from here?
right.
What happens up here?
So they're super wide. This is the right hip socket and thigh bone. And this person you can see has had a prior break there. So we often put a binder on them. We call it a pelvic binder, and cinch these widened spaces down because the pelvis is full of a lot of arteries and veins that bleed a lot. And you can bleed to death from that. Even though there's no blood externally, you can bleed internally from that. So that's what these kind of springy looking things are.
Yeah, I've got a question.
Yeah. Oh yeah.
How do you fix someone that has like a pelvic like that's crushed and stuff?
Yeah, those are orthopedic trauma specialists that are in, like, they're at the big hospitals in St. Louis, and they will use pins and screws, long pins and screws, and try to put that back together. Yeah. And then this is a bad ankle fracture dislocation. So it is an ankle, isn't it? Oh yeah, yeah.
Where'd the foot
That
go?
don't look like a
The
foot.
foot is that way.
Also, it's
Oh,
the
there's, oh, it's still there.
Oh, it's
Yeah,
like
yeah.
the heel of the foot.
Yeah.
Okay, I got you. Like the skin.
Well, it's probably not the heel, it's probably the front, you know, like right here, that it's like bent backwards. Yeah.
Like that. Like
It's
Sorry, I'm having trouble seeing.
That's why it's broken then. That's,
Yeah.
yeah, it's shattered. It's
Yeah. That's what I like to
oh my.
Imagine doing that to your foot right there.
We get these kind of patients, you know, that have these things happen to them. So,
How do you get that one stuck in?
this guy was making a sandwich, he told me. He was making a sandwich and he fell on it.
He's not very good at making.
Yeah.
How does the
Yeah.
second?
Yeah.
Yeah, let's suck it.
He fell on that. He told me it. So.
That's a different night though, right?
Yeah, different night.
It's like no one's making
That person was supposed to
Yeah, that's what always.
Oh, yeah, this is a guy.
supposed to live.
I fixed this laceration on his leg. This is just like on the shin. Shin is a bad spot to get a cut because there's just not a great blood supply there, and this poor kid doesn't want to be here looking at these pictures, I can tell. But he was on an extension ladder, and you know the thing that like makes the ladder get on the next rung, like his leg got caught on it, and he got that cut. So anyway, we put it back together, and it looked like that, and it did pretty well. Huh? Yeah, yeah.
Oh, I see this.
Unfortunately, like he was a smoker, and things don't heal as well when you're a smoker, so that's another reason not to do that.
We got
But
cookies still back here if you guys want some.
yeah, have some cookies
In case
with
you're hungry while you're.
Yeah.
Hey, I'll take
Oh, that's the last one. That's the last picture I got, guys.
Oh, yeah, I'd be happy to take one.
So if you guys have any questions, I'm glad to answer them. I brought some tourniquets with me. If you guys want to play with those, you can. I got to take them back with me. But one thing that we talk about a lot in my line of work is stopping bleeding. And I know that seems real easy. But we have these tourniquets, and a lot of places have, you know, like there's AEDs and things around. Like a lot of places are getting little more like bleeding kits that you might find with the AEDs that have a tourniquet in them and some special gauze.
Yeah.
And so I brought some.
How to put that on?
Yeah, if you want to play with them, we can. I think I brought like 6 or 8 of them.
Don't hurt yourselves with them though.
Yeah.
Only
So
want too long.
come over here. So the only when you put a tourniquet on, you're really only going to put it on arms and legs. So you can't ever put a tourniquet around the neck, and you can't put a tourniquet around the abdomen or around the chest.
You want me to remember everything?
Oh, I'll just use your arm. So when you want to use a tourniquet is when you've got uncontrolled bleeding that you can't get stopped with pressure. So, the first thing to do is if you see somebody that's bleeding is, grab a t-shirt or a cloth or something like that and just hold pressure. And if the wound is right here, you want to hold pressure right over the top of the wound. You don't want to hold it just above it or anything like that. You just want to hold it right over the top. If it's a big gaping wound, like, you know, it would be hard to get it on an arm, but like on a leg or on the abdomen, you could even pack into the wound. And, you know, apply pressure that way, because in the abdomen, you know, blood vessels can be coming from all different directions. So if you pack something in there tight, you're providing like internal pressure. But if you're holding pressure and you can't get the bleeding to stop, or you're you know, you're all there by yourself, and you know, you need to call for help, and you need to do other things that require you to have both of your hands, a tourniquet comes in real handy. The other kind of bleeding you would think would need the tourniquet would be the kind that you see squirting with every beat of the heart. You know, like that makes you think that there's an artery that's injured, not a vein. And so arteries, this looks like an anatomy room. Arteries come off of the aorta, and they are carrying oxygen to the tissues of the body, and there's a lot of pressure behind them. So you can bleed to death from vein injuries, but usually arterial injuries are the ones that are going to be bleeding more vigorously. Usually arterial blood is red, like the red on the straw and on your lanyard, it's red. It's not like maroon colored. So when the oxygen goes away, it's darker in a vein, and when it's in an artery, it's red colored. So if you have access to a tourniquet, you put this on and tighten it down. Okay, these have Velcro on them, and you know, this is, I don't have it super tight, but I'm going to tighten it down with this bar. Okay, so these are called CAT tourniquets, combat application tourniquets. So like they carry them in the Army, with all the soldiers have them with them. And so what you do is you twist this down, okay? And you twist it until the bleeding stops, or until for some reason you couldn't twist it anymore. And then this little you know, piece of plastic, it hooks underneath there. And so you don't have to have your hands on the victim anymore. So that's really nice. So, you know, you want to go until you see the, I mean, sometimes if it's a big leg or something, it may be really hard to get it tight enough. But that's what we use tourniquets for. A lot of people, you know, we see tourniquets applied unnecessarily, and that's okay, you know, or we see them not tight enough. If you have somebody who has a thigh wound, and they have big muscular legs, or they're real heavy set, you know, obese legs, sometimes you put 2 tourniquets on, and you want the tourniquet to be just proximal to the wound, okay? So if you put it down here, that's not going to help. You have to put it above the wound, closer to the shoulder, closer to the hip. It's hard, you can't really put tourniquets in the groin or like in the armpits. You know, that's another area. There's big blood vessels there. The blood vessels are bigger, closer to the inside, you know, closer to the center of your body.
Things to watch out for with tourniquets, like, because isn't it like when they get removed, isn't there like a whole lot of toxins that they?
Yeah, so, you know, if the bleeding can be controlled with pressure,
Yeah.
I mean, that's the preferred thing to do.
Sure.
And pressure can't be like underrated. I oftentimes will set like my watch and be like, I'm going to hold pressure for 5 minutes, and almost all the time the bleeding is, you know, slowed down a lot in 5 minutes time. We do that in the operating room when we get into these big bellies like this, and we pack all these big gauze pads in there, and then we kind of stand and we're going to let this try to create some clot in there, you know. But when you take there, I mean, there are a lot of sequelae from tourniquets, but I don't want that to discourage you from using it if you feel like you need it. But yes, I mean, people can get sick. There can be reperfusion type things. But once you make the decision to put the tourniquet up, and you've called for help, and you've called, you know, the ambulance is on the way, you just leave it there and we'll deal with it at the hospital. You don't want to keep checking on it, let it down. Oh, is it still bleeding? There's no need to do that. You know, I mean, if the blood is squirting across, or if it's created a big pool under somebody, you know, you or somebody else, I mean, that's something that needs some attention.
You guys probably give a lot of blood to people.
We do.
So like, is it pretty much all O negative that you go for? Or like, is there situations where you have time to test what type of blood they have or?
Yeah, so we have protocols at the hospital, and we have one that's called a massive transfusion protocol, which we give that if we think someone is really, trying to bleed to death on us. And that's usually negative blood, unless it's a male. You can give O positive because they haven't had a child, so they can have O positive blood. Then what we do at the same time when we're giving that blood is we've sent off labs, and so the blood bank is working on screening the blood and then trying to get type specific. So
they come back pretty quick with your results?
Yes,
Okay.
yeah. So our massive transfusion protocol, the blood products that are given are red blood cells, plasma, and platelets. And
So they're all separated?
They're all separated.
Wow.
We don't give whole blood.
Huh, I did not.
Not many places give whole blood.
Okay,
I mean, except the military does, but.
yeah.
And I think some big institutions in the country do, like Houston and big places like that.
I never heard that.
Yeah.
Wow.
So when you see the red blood hanging, it's only red blood cells. And then if it's yellowish, greenish, sometimes green colored, it's plasma, which has all the clotting factors in it. And then platelets are separate. Yeah. Any other questions, guys? Yeah?
I do want to ask, so like, you obviously do work in the operating room, right?
Uh-huh.
And I was wondering, like, kind of, what's your main role in there, like, during surgery?
Yeah, so during surgeries, the surgeon is the leader in the operating room. And so he or she is determining what procedure we're going to do. I mean, they've had extensive medical school plus 5 or 6 years of residency. They know the anatomy forward, backwards, what artery comes off where and attaches where and supplies blood to what area. And my role is as an assistant in the operating room. So a lot of times I'm retracting organs, or maybe I have a tweezer. They're called forceps, but a long tweezer to grab a vessel if it's bleeding, or to help, like if we have to take out part of the intestine and to hold it when we're hooking it back up. And so that there's a lot in surgery that there's a lot of physics in surgery, and so you don't want to create tension in places where there doesn't need to be tension. Like you don't want knots to be too tight or tugging too much because the tissues are very fragile. Different tissues can take different levels of tension, so like the intestines are very fragile as opposed to like muscle or bone that can take more. So that's kind of my role in there. Suctioning, making sure the lights are right, oftentimes I'm closing the skin. So the scars that you see after surgery or people like me are doing. Yep, that's a good question. Anybody else? Okay, sorry if I grossed anybody out. I feel like a few people had more color in their face when they walked into the room. I forget about it because, this is like lunchtime talk at work, so.
Ew.
Yeah,
It makes
I
me feel
mean-
any better. I had a blast. I love that entire thing.
Good, good.
Thank you very much.
Yeah.
Thumbs up, man.